Hello, and welcome to the webinar COVID-19 in Long-Term Care Facilities, an update. I have the honor and pleasure today to introduce our presenter, Dr. Joseph Ouslander. Dr. Ouslander is an internationally recognized geriatrician. He is professor of geriatric medicine and senior advisor to the Dean for Geriatrics at the Charles E. Schmidt College of Medicine at Florida Atlantic University. Dr. Ouslander is also a courtesy professor at the Christine E. Lynn College of Nursing at FAU as well. Dr. Ouslander is also the executive editor for the Journal of American Geriatric Society. Furthermore, he is the creator of the Interact Quality Improvement Program. In addition to all of these prestigious positions, he serves on the CMS Nursing Home 5-Star Panel, the Federal VA Geriatrics and Gerontology Advisory Committee, and we are honored to have him as a senior medical advisor for Pathway Health. Handouts are available under the handout section on the navigation screen. We will be taking questions at the end of the presentation. Please feel free to ask your questions in the chat box. We are fortunate once again to have Dr. Ouslander share his knowledge with us today. With that, I would like to present to you Dr. Ouslander.
Well, thank you, Sue, and it's a pleasure to be here, and thank you all for attending. I'm very fortunate to be able to work with Pathway Health. They're just absolutely fantastic, fantastic people. So I'm able to do this presentation and prepare this presentation and update it because my university considers it part of my scope of work and my position. And so I need to make sure you know about Florida Atlantic University because it is confusing. FAU is one of 12 public universities in the state. And we have over 25,000 students, largely at 4 campuses. We have a fully accredited medical school, and internal medicine, emergency medicine, surgery, and neurology and psychiatry residency programs. We have a college of nursing, a college of medicine, and we have a beautiful campus. You can see it's right near the Atlantic Ocean. We're on the east coast of Florida, and we have brand new dorms, and we have a brand new football stadium. And we were planning to go with the Pathway Health folks to the opening game of the season, which is the University of Minnesota and FAU. I'm not sure we'll be able to do that, but we're going to see if we can. So I have to do disclosures. I've had a lot of grant support through Florida Atlantic University from the entities listed here to develop and disseminate the Interact Quality Improvement Program. And myself and my wife do receive royalties from FAU and Pathway for the training and licensing of the program. All the work on funded Interact projects is subject to the terms of conflict of interest management plans, which have been developed and approved by my institution's financial conflict of interest committee. So it's all above board. But I do, part of those plans are to make these disclosures. So the first point I want to make is thanks. We have to be thankful for and appreciate all the team members who are providing direct care, risking their health and the health of their families every day. We know they're all working hard, and many will continue to work when staffing is short. And we must therefore pay attention to their concerns and encourage them to stay as healthy as possible, even in this challenging time. So we need to support our team members. Lisa Thompson from Pathway made me aware of this article that was published recently in JAMA, and where they did a qualitative analysis of requests from staff, healthcare staff, and you can see that they were categorized to hear me and protect me, prepare me, support me, and care for me. So we need to realize that even though these people are working very hard, they have concerns, and Also, to the extent possible, I know people are working hard, try to maintain a good diet and exercise as possible to the extent you can, and other things, whether it's meditation, mindfulness, or reading or something. Try and support that with team members. I know that they also have families and many have second jobs, but it's really important for them to try and stay healthy. So just a few comments. I know the audience here is familiar with long-term care, but I just want to comment on the terminology that I'm using in this presentation. So long-term care facility in this presentation is a broad term, but in this presentation, it is really focusing on skilled nursing facilities, and nursing homes. And people who reside in these facilities are there for different reasons, and they differ clinically. So I've actually, over the last 2-3 years, really, when I talk and write, call people who are in a skilled nursing facility for post-acute care after discharge from the hospital as a patient. Many of them are patients, they're sick. People who are there for requiring long-term care, they call residents. And whether they're patients or residents, they're generally at high risk for complications of and mortality from COVID-19 because of multiple chronic conditions and altered age with altered immune function. So some important points to note about the presentation of COVID-19 and the importance of infection control. So we know from a number of reports in the literature, in the news, and also many reports from facilities around the country that long-term care facility patients and residents frequently do not have typical symptoms and signs of COVID-19. Many have no symptoms for quite a period of time, or just have no symptoms ever, and that could be up to 50% or higher in a particular facility. Some have atypical symptoms, so they don't have the cough and the shortness of breath and fever. They may just have a low-grade temperature elevation, altered mental or functional status, GI symptoms, as well as other symptoms. The other complicating factor is that long-term care facility staff may have no symptoms, no fever, and pass multiple screening tests and still be infected. I'm not talking about people who are coming to work when they should be, when they have symptoms. I'm talking about totally asymptomatic people. They also may be working multiple jobs at different facilities and be at high risk. So they can therefore infect other staff and residents without even knowing it. And so I'll talk more about testing and answer questions to the extent I can about testing. But right now, the only way to prevent this infection and further spread of the infection is behavior. It's intensive infection control. And even that may not spread, prevent all the spread. But this must be continuously reinforced with everybody that's working in long-term care. There's no prevention, there's no treatment right now other than intensive infection control. So with regard to the use of protective equipment and isolation, I know that some areas have different rules and such, but what I'm saying are a combination of federal rules and others' recommendations as well. But all staff should use some form of mask, not a scarf, that's not effective, and maintain social distancing and wash and sanitize hands frequently and try not to touch their face. There are CDC guidelines. Repeated education about this is essential, and as much signage as possible. As much PPE as is available should be used with any patient or resident suspected of having COVID or has an acute changing condition without an obvious cause. So PPE should also be used during high-risk procedures or close contact procedures, such as nebulizer treatments. And I'll talk more about drug therapy a little bit later, but nebulizer treatments should not be used unless they're absolutely essential. Should use meter dose inhalers with a spacer if that's at all possible. But because the symptoms and signs can be atypical in the people we're taking care of, we have to have a low threshold for placing patients and residents on precaution. I strongly recommend that anyone that has any suspicious change in condition, acute change in condition, be suspected of being infected until they're proven otherwise. And this would include regular monitoring, which is highly recommended, checking vital signs and for other acute changes in condition frequently, such as every shift. Now, I understand that having a low threshold for isolation and quarantine and isolating all new admissions from the hospital, which we'll talk about a little later, can be especially hard for this population. I understand that, and there were already a couple questions before this webinar submitted about that topic. You know, to the extent possible, regular contact with family and friends should be maintained using video calls and social media, which for many of the people we care for will require help from staff. And frequent check-ins are important both for human contact and to identify changes in condition. But to proactively answer the questions, I understand the mental health potential consequences of isolation and quarantine in the population under our care, but it's just social responsibility as well that we have to. The only way we're going to contain this pandemic is to use intensive infection control procedures and isolate people who are suspected of having viral infection. And I say this in the context recognizing that there are shortages of PPE. They'll persist, they'll probably persist and will recur in many areas. There are CDC guidelines that should be followed to preserve PPE. The availability of testing is variable and is still hard to get in a timely way, except during suspected outbreaks and clusters. And I'll talk more about this. The interpretation of single tests is very challenging for a number of reasons. So this further highlights the necessity of intensive infection control procedures. And I know people who are on this call, the facilities that they work in or affiliated with, probably have had very variable experience with the availability and results of testing, and maybe some can share their experience at the end of the presentation. So there are ways we can change our practices, take advantage of this pandemic to change our practices for the better. So first, clinicians should do as many visits as possible over the phone or by telemedicine if it's available. And CMS is really facilitating telehealth visits and has relaxed the rules for requirements for in-person visits. And we've been harping on this in the Interact program for over a decade, that facilities should be using tools to determine what needs immediate versus non-immediate notification of a clinician. I use the term clinician for primary care physician, nurse practitioner, physician assistant, and what can be evaluated by the phone or telemedicine if it's available, and it's becoming more available. There's an ANDA practice guideline on notification. The Interact changing condition cards and Care Pass have very specific guidance, and they're available for free for clinical and educational use on the Pathway website, and much of this guidance is embedded into the Interact program for those who use point-click care. So another opportunity is to change the way we prescribe medication and to look at deprescribing. This is something that I've spent a lot of time on, and I've always tried to practice clinically. Some real experts got together under the auspices of the University of Maryland School of Pharmacy, in collaboration with the American Medical Directors Association, and had other people like myself review some guidance on optimizing medication management during the COVID-19 pandemic. It's a very thoughtful document. It's got very specific implementation tools. It's available at the website that's on this slide. And I've boiled it down to a couple of slides. Reducing the number of medications, number of doses, and monitoring parameters will reduce risk of viral transmission. It will reduce the number of interactions there are between potentially infected staff and potentially infected residents. It will decrease staff burden and time at a time when there's a staff shortages. So the overall strategies are to discontinue the discontinuation or reduction of unnecessary or minimally beneficial medications and monitoring. Changes to medication formulations and dosing regimens to minimize doses and administrations, and appropriate alignment of medication administration times. So examples for discontinuation, at least temporarily, and I'm happy to discuss any one of these individuals, are vitamins and herbals. I've said for many years that most vitamins older people take, unless they're proven to be deficient, are just expensive. It could make an expensive urine. They're just not, all people on multiple vitamins and herbals, that really needs to be looked at if it's being administered to them. DocuSate is a pet peeve of mine. I know it's prescribed for tons of people in long-term care, never been shown to be effective, and there are other better ways to manage constipation. Appetite stimulants shouldn't be used. They're not effective. They have side effects. With one exception, I would say, which is mirtazapine or Remeron in the setting of someone who's depressed and not eating. Cranberry tablets probably are not effective, not the most effective approach to recurrent urinary tract infections. Probiotics are helpful if someone needs to be on an antibiotic, but not chronically. They're never been shown to be beneficial chronically. So this serendipitously is a picture, a diagram from an editorial I wrote over the holidays and was published in the Journal of the American Geriatric Society in March, called Improving Drug Therapy for Patients with Life-Limiting Illnesses. Let's take care of some low-hanging fruit. There are several classes of medicines that are not only inappropriate at the end of the day, because there's no evidence they're effective, but their risks probably outweigh their benefits. And those include statins, anticoagulants such as prophylactic aspirin. And just this morning, I was on a call looking at root cause analysis, listening to root cause analyses of hospitalizations. And there was a patient on low dose aspirin for questionable indications who was basically a candidate for palliative care, who had a massive GI bleed from gastritis. It's just one example that occurred this morning. Cholinesterase inhibitors are another pet peeve of mine. They have no benefit at end-stage dementia and several adverse effects. Over-treatment of hypertension has no benefit, risk of falls and syncope, and staff monitoring for blood pressure checks and whole parameters is time-consuming. And over-treatment of diabetes with high risk for hypoglycemia and too much unnecessary staff monitoring finger stick glucose levels. So this is just good practice, and you can see in this colorful diagram here the percentage of people with life-limiting illness who are still on these medicines. I mean, it's just low hanging fruit was the best term I could come up with to describe it. And I'm hopefully going to be working with some organizations to implement these guidelines. And they'll be helpful after the COVID-19 epidemic is gone as well. So another issue that's come to the forefront that we can take an opportunity to take advantage of is advanced care planning. The mortality rate from COVID-19 will be high. We know this already. I have been fortunate. I have not actually personally been involved in a facility with a cluster. But I've heard many others speak about it, and it's awful. And clinical deterioration can occur rapidly in hours. So I think we need to work together to conduct advanced care planning discussions and update advanced directives in light of this pandemic. So the pandemic really provides an opportunity to hold these discussions, which may have been difficult previously, and to create directives that may be initially specific to the pandemic. This requires a team approach, and ultimately it requires a trusting relationship between the patient, resident, and the team. If you have access to local palliative care and hospice clinicians and teams, they can be very helpful as well. And I know these discussions can be challenging, but I think we need to take advantage of them. And there are many educational and documentation tools available. So examples include using evidence on prognosis. There's a great website called www.eprognosis.com that's run out of University of California, San Francisco. And it has simple language descriptions of risk and benefits, such as those, the example of education on CPR for residents and families that's on the Interact website. I want to just take a moment to talk about DNR. DNR is one care limiting order, but in this situation, we're going to face clusters of cases and facilities. DNR isn't enough. DNR is specific to limiting cardiopulmonary resuscitation. The success of cardiopulmonary resuscitation in our population is almost zero. It's a medically futile intervention almost all the time, and shouldn't limit any other care. So the discussions need to go beyond DNR, and DNR shouldn't be over-interpreted. There are some COVID-specific tools on the websites listed there, and they're in the resources at the end as well, that are really very good. The other thing is documenting and communicating discussions and decisions is critical, so that hospital transfers and other interventions are either implemented or withheld based on the patient, resident, and family preferences. The other thing is, I'm sure many of you are aware, it's there in many facilities, unfortunately, people are going to die there from respiratory illness, from respiratory distress. So everyone should prepare their emergency kits and stock them with medications for comfort for respiratory distress, including liquid morphine, lorazepam for the anxiety associated with the distress, and atropine to help diminish secretions. So I'd urge everyone to make sure, to the extent they can, make sure they have adequate drugs in their emergency kits. What about interfacility transfers? Well, there are federal, state, county, and local regulations and guidance, and it varies. I think this is, again, a time to reinforce the fact that long-term care facilities should limit transfers to emergency departments and hospitalizations to clinical conditions that require specialized testing for acute or ICU level care. Again, we have AMDA clinical practice guidelines, we have the Interact program, We have other similar tools to help manage patients and residents in the facility whenever safe and feasible. And it's very important to provide complete clinical information. The picture on the right shows a little image of the nursing facility to hospital transfer form in Interact and e-Interact. There are many others, but it's really important to get that information to the hospital. And part of that information has to be advanced care directives. They should be documented and sent to the hospital so that preferences are known and honored. And similarly, what about admissions to long-term care facilities from hospitals? Well, again, this varies locally, by state, federal, there are state rules and county rules and public health departments involved. But some general principles are that hospital patients should be discharged home whenever enough support is available to manage them safely outside of a post-acute care facility. That's the preferred discharge. Unless otherwise overridden by state, county, or local regulations, COVID-19 positive patients should no longer have symptoms and 2 negative tests 24 hours apart before being transferred from the long-term care facility or meet CDC criteria. Now, I mentioned about the tests. Currently, the tests that are being used generally have a 30%, 1 in 3 false negative rate. So even 2 tests that are negative, there's a small 5 to 10% false negative rate. You have 2 negative tests and still be infected. So, and they should have no fever or respiratory symptoms for 72 hours and 7 or more days since the onset of symptoms. But any patient being transferred from a hospital to a long-term care facility for any condition without a COVID-19 test result or only 1 positive test result should be presumed to be infected and isolated for at least 7 days, and most of the recommendations are 14 days, and asymptomatic. So in hospitals, like facilities, really you need, as best as possible, they need to provide the critical information necessary to care for these patients. It's especially important where clinicians and other health professionals can't access the hospital electronic medical record easily. And again, I want to emphasize the importance of getting information on advanced directives and discussions that were held in the hospital if you can get those. So let me talk a few minutes about some of the future issues here. I mentioned testing quite a bit. So as rapid testing and self-testing become more available, it will be easier to test patients and residents and staff and quarantine them as appropriate. There are many different tests for the viruses available, but false negative and false positive tests occur frequently enough to make interpretation and decisions challenging. So I mentioned the 30% false negative rate. So a big area that's being explored now is testing for serum antibodies, which can help identify people who have been infected. This may help with quarantine and staffing decisions, but levels needed for protection and duration of immunity are not known. We just don't know enough about this right now. Some people, and I'm sure you've heard this on the news, some people, their convalescent serum or plasma could also be used as therapy. It is being done. I just was on a call with the Florida Medical Directors Association and heard about a health system that was using it, and they've used it in 2 patients already. But it's not clear that all people develop high enough antibody levels and what levels they need. And the duration of immunity is unknown. It may be a few months, but it's not known. So until we have better tests, the best testing strategy is unclear. I don't know the answer to this. Assume tests were available. Should we test all staff and patients and residents regardless of symptoms? Should we test all staff only, and just all staff, and only test patients coming from the hospital and those with symptoms? And what about those go out for tests and treatment? So I'm very nervous. In the facility I work in, we admitted 2 gentlemen in the last couple of weeks who go out 3 times a week for dialysis. They're at high risk for infection to begin with, and now they're going in and out of the facility 3 times a week. So most of you are aware that just the other day, there are new CMS reporting requirements that I think are in general good. Transparency is good, but I understand the regulatory and legal liability issues are legitimate concerns. I'll be happy to answer more questions about testing to the extent that I can answer them. I'm certainly not an expert. What about treatment? Now, what I have underlined there has been published in the last 4 or 5 days twice in by major organizations. So there was a review in the Journal of the American Medical Association. There were recommendations released from the Infectious Disease Society of America. And just yesterday, an NIH panel released its recommendations on treatment of COVID-19. And the answer is, there is no evidence-based drug treatment for COVID-19. As you know, there's someone at the top level of our government pushing hydroxychloroquine, or has pushed it, and that drug, with or without it, azithromycin, which is also an anti-inflammatory drug, may be helpful in treating the intense inflammatory response that occurs. What seems to be killing people is the inflammatory response, the so-called cytokine storm. But the data on hydroxychloroquine are anecdotal. The results of controlled trials are pending, but unlikely to include long-term care patients. So even if they conduct trials, we don't know if the drugs are going to be, we may not know if the drugs are going to be effective in the population that we serve. You should know that hydroxychloroquine has numerous potentially severe side effects, including sudden death in people with a prolonged QT interval, electrolyte and liver function abnormalities, and many others. Several potentially serious drug interactions, and guidance on dosing, which was intended for hospital, was removed from the CDC's website several days ago. If it is used, consent should be documented and EKG performed before treatment, and preferably in the context of a clinical study. I have been on calls where there is a very high incidence of COVID in nursing homes in New Jersey and New York, and the primary care physicians are prescribing this to patients without a positive test. I think that's not a good practice, because sometimes you're not treating COVID. You may be treating influenza, you may be treating pneumonia, but not COVID. And you're exposing patients to a very risky drug. So in terms of other drugs, there are many different drugs being looked at: antiviral agents, immune modulators, and convalescent serum and plasma. And vaccines are under development, which we really need. So there has been a need in many areas of the country to prepare alternative sites of care for people coming out of the hospital. I don't have direct experience with this, but I've read a lot about it. So this could involve converting entire long-term care facilities, using unoccupied wings of existing facilities, taking advantage of critical access hospitals with swing beds where they're available, and building temporary facilities, and even using other sites, hotels or unused university dorm rooms. But the planning is very complicated, and it requires cooperation between facilities, hospitals, county and state authorities, and there are a lot of regulatory, financial, and liability issues. And of course, staffing and adequate PPE will be challenging. And if anyone has experience with that and they want to share it with the group on this webinar, that would be This is a very thoughtful piece about a framework for preparedness going forward in COVID-19, authored by David Grabowski, who's a health policy professor at Harvard, and others, that will be published online in the Journal of the American Geriatric Society as soon as I can get online and accept it, and they can get it up on the website. So that should hopefully be within the next, should be up on the website within the next couple of days. It's very interesting, describing 4 stages: survive this current surge, regroup and prepare. In the second stage, restructure to recovery based on what we've learned, and redesigning reality. I really think one of the messages here is that we're all learning a lot, and this pandemic may help us change our practices for the better in the future. So I'd recommend you looking for that. And the website where that's available now is on this slide. There are many opportunities for research. We can continue to learn for years and be better prepared for future pandemics. The development of highly accurate rapid tests can help understand the spread of the virus and prevent future outbreaks in clusters in long-term care facilities. I'm trying to actually, our university is, our College of Medicine is doing a study of some of our residents who are being exposed, who are going and working in the hospital, and they're using a monitor that monitors temperature frequently, and typical Fitbit monitoring parameters, and then doing repeated testing. And I think that would be a very helpful study to spread to long-term care facility staff. The development of effective treatments, including the ones already mentioned, that could help eradicate this virus and prevent future waves and other deadly viral diseases. And I will say that and my wife will verify this, that I have been saying since the beginning of this pandemic that there will be one or more waves of this, because there are many people in our society that value their ability to get out and be with other people more than they value protecting our society from another wave of this deadly illness. So it's going to happen, and I'm afraid we're going to continue to have clusters and outbreaks in facilities. So there are many other areas for research, including the effects of all this social distancing on mood and behavior, changes in preferences for intensity of care in the presence of life-limiting illness during the pandemic, the effectiveness of innovative virtual teaching strategies, and many, many others. So you'll receive a copy of this, you should receive a copy of this presentation. There are some websites on the slides. There's some websites recommended to go to, some direct links to some articles, and there's things coming out multiple times a day, so it's hard to keep up. And with that, I'll stop, and we'll try and answer questions and encourage people, if they have comments or want to share experiences, to do that.
Thank you very much, Dr. Ouslander. That was excellent presentation. Please feel free to type in your questions in the chat box, and then we would be able to present those to Dr. Ouslander.
Sue, if someone wants to share experiences with their experiences in any of the things that I mentioned, that would be good too. They could be unmuted to do that.
Excellent.
We did have a few questions come in during the presentation, so I can start with those. The first one was, is there a care path for COVID-19?
So it's a good question. It's not labeled a care path for COVID-19, and I don't want to continuously tout the Interact program, but this is what the Interact program is exactly designed to do. if you look at the Interact care paths, they encompass the types of presenting symptoms that people have. So there's a care path on fever. There's a care path on shortness of breath. There's a care path on suspected lower urinary tract infection. There's a care path on altered mental status. They're no different. They're just no different. You might want to add COVID testing if it's available, but I don't think I would approach it much differently.
Okay, thank you. The next question was, has any hospital tried to treat with a hyperbaric chamber?
I have not heard of that at all. So it's actually an interesting question, because there are some people I've read about and listened to who believe that the acute respiratory distress syndrome in COVID-19 is being treated improperly with ventilation, because what they're saying is that the problem with that the COVID virus causes is low oxygen. It's not like when you put an older person with pneumonia on a respirator, it's generally a combination of low oxygen and weakness of the respiratory muscles and mental status changes that prevents them from oxygenating their blood. In a lot of the younger people that have had the acute respiratory distress syndrome, they're with it. They have strong muscles. They can breathe. It's just that they need oxygen, and using the typical ventilator parameters may be the wrong thing to do, and could theoretically cause permanent damages to the lungs. So I think that's the basis for the question for hyperbaric oxygen, but I have not heard any reports of that.
Thank you. The next question was, what would be the best use of serum antibody tests for residents, for staff, and is timing an issue?
Yes, I tried to allude to that. So I don't know how to answer that question, and I alluded to the problems, because there are tests that will measure antibodies. So when you do that, you can measure many types of antibodies, but there are IgM antibodies that occur early in the course of a viral illness. And then a week or two later, you develop IgG antibodies. And what the levels are that confer protection against a virus and from viral shedding and how long they last are totally unknown. And so that's why I just don't know what, and I don't think anybody knows the answer until more studies are done. I do think if you're going to use a reliable antibody test to determine if staff can come back to work, or if you have COVID positive patients and you want to staff a unit with people who have had the illness and are now asymptomatic, the antibody testing might be helpful in those judgments with the caveats I mentioned before. I personally think that a rapid test to see if somebody has the virus, my personal thought about this, we haven't worked this through in the company that I work with now, but my personal thought about this is to push to test staff and repeatedly test them every 7 to 14 days, because they, in an ongoing way, they're going to be the primary vector that brings the virus in and out of the facility. I think we can mitigate most of the risk of people being admitted from hospitals by just isolating everyone and using PPE. But staff is just tricky because they can be asymptomatic. I personally go through 2 screening tests. I go through a screening test at the gate, and I go through a screening test when I get to the facility. I could be shedding virus. I could be asymptomatic. I could be spreading it. So I think a rapid test where we could test all the staff and people that are coming in and out of the facility, that would be the most helpful approach, but that's just my opinion.
Thank you. The next question is there any criteria for discharging of long-term care patients back to their homes and society?
Yeah, that's a good question. Well, yeah, well, first of all, I think if you're talking about the long-term care residents, there's a reason they're in the long-term care facility. They don't have the resources to be home. Some families might want to take someone home, and I think that's occurring. I would use the same kind of logic. I wouldn't be comfortable discharging anyone unless they were, asymptomatic and had a couple negative tests. I just think the risks are too high, and you just don't know who has the virus.
Next question, do you support requiring COVID testing in the hospital on all patients prior to discharge to long-term care, even if patient is asymptomatic?
I don't think, I think that that kind of decision is a good question. I think that decision has to be worked out between long-term care facilities and their local hospitals, and depends on, the prevalence of the disease and the availability of beds, and whether there are already positive patients in the facility or not. So to answer the question more directly, I would say in certain circumstances, I think it's impractical and unnecessary to require testing. But I've learned to be much more conservative about these things as I've grown older. I think that, as I said, and I'll reiterate, the patients being discharged from a hospital to a long-term care facility, the only way I wouldn't isolate them is if they had an illness that was totally unrelated to COVID. They were not in a COVID unit in the hospital. They had absolutely no symptoms suggestive of an infection, and they had 2 negative tests. I would consider not isolating that person on admission to the facility. Anyone else coming from the hospital, no matter what they were there for, no matter what symptoms they have, even if they have 1 negative test, false positive rate of 30%, I would isolate them. And many recommend 14 days. I think seven days without symptoms at all might be okay. But, so I want to be very clear about that. And I understand that isolation is bad. I understand it's going to be a problem with facilities burning through their PPE, but it's the only way we're going to prevent the perpetuation of clusters of this illness.
Next question is, how will plasma treat positive COVID cases?
Yeah, so good question. So this has been used in other viral illnesses. And so when you draw blood from someone, you centrifuge it and take out the red blood cells. And when it's been anticoagulated in the test tube, it's called plasma. When it's not been anticoagulated in the test tube, it's called serum. And the plasma and serum contain proteins, and that includes antibodies. And not the red blood cells. So that's injected into a patient with the disease, with the theory that the antibodies in that plasma will be enough to bolster the immunity of the patient with the disease and help them fight it off. That's what's being studied now.
Next question is there a possibility of herd immunity and what impact it can have on the second wave of infection?
Very good question. Yes, there's a possibility of herd immunity. I think we're already seeing herd immunity in the so-called leveling of the curve, the leveling of the incidence of the disease and the hospitalizations and the deaths in some areas. Part of that is due to herd immunity. It's interesting. I'm sure most of you are aware that the Prime Minister of the UK was in favor of just allowing this pandemic to spread and getting it and taking care of it by herd immunity. Same thing in Sweden. The Prime Minister ended up almost dying from the disease, and the death rate in Sweden is very high. So herd immunity can be helpful if enough people are infected, but that shouldn't reduce the efforts to continue social isolation as hard as it is on people and as hard as it is on the economy. I personally think that we're going to have to be careful in public for several months. And I don't even know if that will prevent another wave of the disease, because I don't think all people will be responsible in their social isolation.
Next question, can you recommend strategies for managing discussions with physicians pertaining to medication overprescribing?
That's a good one. So that's tough because a lot of physicians are pretty fixed in their prescribing habits. I actually, when Dr. Mark Beers first established his Beers criteria, I was his mentor on that project many years ago at UCLA. And we had discussed those type of strategies by trying to give physicians evidence-based recommendations. We never got to test that. So I think it's a combination of the personal relationship with the physicians. I think it takes a strong medical director to do this. The guide to prescribing that I referenced, and there's a link to, actually has template letters to physicians and patients and residents that you can modify to use about this. So I think it's a combination of being a medical director, being comfortable talking to primary care physicians about the issue and making evidence-based recommendations, which is one of the reasons I wrote the editorial I did, so that people could hand doctors the editorial and say, here are the data. And this prescribing guide is written by a bunch of real experts. So I think it's a combination of personal relationship, using evidence, and trying to, and also monitor, you will have to make sure with some of the medications you don't cause problems. But I think I think those are the approaches I use, but I understand it's not easy.
Next question is, could you further clarify long-term care admissions from hospital? As I understood that long-term care skilled nursing facility still needs to admit COVID-19 positive patients unless they do not have PPE staffing to properly meet their needs.
I think that varies. I think there have been states that have done it both ways. They've said they can't go, they can't go to skilled nursing facilities. In some states say they must go to skilled nursing facilities. So I think that varies. Yeah, I think it's a complicated decision based on the needs of the community and the relationship with the health system. And I'm not sure one answer fits all for that question.
Next question. What guidance would you provide in transition of a positive COVID resident that is now testing negative in the long-term care facility back to the general nursing home population?
I haven't thought about that because I haven't faced it, but I've heard other people talk about it. And so let's just say that a facility has a unit where they're putting all COVID positive or suspected COVID positive patients and staffing it, maybe with people with staff that have known have had the disease. So I would treat it the same way I would treat it at the hospital. Same. In other words, 2 negative tests, 24 hours apart, no symptoms, for at least 7 days if they had symptoms. But that's just an answer kind of off the top of my head. It's a good question.
We have time for a couple more questions. Any of the questions we don't get to, we will make sure to send and get responses, but a few more questions. When the flu season hits, at what point do we know if it's the flu or COVID?
So that's a very good question. So right before this webinar, I was on the Florida Medical Directors Association webinar, and I pointed this out. So there was a study published in the New England Journal of Medicine, either New England Journal of Medicine or JAMA. I can't keep them track because they're studied published every day, about co-infection in COVID patients with other viruses. And it showed that patients who are COVID positive can have other viruses, but they focused on rhinovirus and enterovirus. They didn't study influenza virus, number one. But they also didn't study the question that needs to be answered. And the question that needs to be answered, and I'm not sure, hopefully it could get answered before the flu season starts again, is if you see a patient with, well, it may become a moot point if rapid testing is available. But right now, let's say that you saw a patient with a respiratory symptoms. Most facilities have access to a rapid flu test. If you knew that if the rapid flu test was positive, there was a very low likelihood that they could be COVID positive, that would be very helpful in decision making. But we don't know that. We don't know if having influenza protects you from COVID. And so, but I still would do the rapid flu test, because if it's positive, then we have treatment that can be initiated. But it's a very good question, and I think people are going to try and study that.
Okay, we'll do one more question. What is your stance on converting a long-term care facility to an all COVID facility to help minimize spread to other residents, hopefully reduce deaths, and help hospitals free up beds for ICU?
Well, I made a slide on that, and if people are interested in detailed, one set of detailed recommendations about that, the California Association of Long-Term Care Medicine has written recommendations about that to the state of California. One thing that, apart from the development of facilities, and so there's some things that need to be addressed in order to even consider that. One is, where will the staff come from? How will they be trained? And will there be adequate PPE for a facility or a unit like that? That's number one. Number two, I think there's a really good idea and I wish that more and more people would, more and more places would try to implement it. And that is to create kind of a command and incident control center with the expertise necessary to answer questions for long-term care facilities, so that they don't have to develop their own expertise. Perhaps the state or a county could appoint a panel of experts to answer questions for them, so they can go about the business of taking care of these patients. Now, having said that, I think that developing a unit, converting a facility, or building a new facility depends on local needs. But as I alluded to, as I started thinking about this and talking to other people about it who have been involved, there are people who have been involved in this. Just think about not only the staffing and the PPE. There are state and county regulations that you may have to work around, as well as federal regulations. There are payment issues. Who's accountable for the staff? Who's going to provide the staff? Who's accountable for it? Who's going to pay the staff? And what about the liability issues involved, and who's liable? So, for example, if I am involved with an organization that has an empty unit that could be used for that purpose, but the steps to get that done are very, very complicated. So I don't have all the answers to that. There are people that have direct experience with doing that, and I would recommend, and if you want me to, I can actually send, Bridget, I can send the document from the California Association of Long-Term Care Medicine that is more specific about some of these issues.
This was so informative. I would like to thank you once again, Dr. Ouslander, for this exceptional presentation. And we had such great questions, and your responses were fabulous. Once again, you can download the presentation handouts under the handout section under the navigation screen. Thank you very much for attending, and have a great day.